The Next Breast Thing podcast is primarily funded by the American Society of Breast Surgeons. The support of sponsorships helps us offset some production costs. ASBrS does not endorse or co-promote any company, product, or service mentioned.
This episode of The Next Breast Thing is made possible in part through the generous support of Solventum Prevena Therapy and Mammotome.
Solventum Prevena Therapy has demonstrated a significant reduction in surgical site complications, infections, and readmissions. Take a proactive risk management approach. With Prevena Therapy, learn more at Prevena.com. That's Prevena.com.
At Mammotome, we offer a comprehensive range of products that deliver better outcomes in breast care. From biopsy to surgery, our advanced technologies empower clinicians with precise, trusted solutions. Together, we will transform the future of breast care. Learn more at Mammotome.com.
Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast, wherever you listen to podcasts.
On this episode of The Next Breast Thing,
The top 10 reasons why our listeners don't want to miss the 2026 ASBrS Annual Meeting.
Seattle has the Space Needle, and so our idea was moving the needle.
Chat, GPT, Perplexity, AI, something.
And you're looking at all the different things that are available to us. You really see how much technology is.
So hot off the press.
Yes, the SP robot was FDA approved for breast surgery. When I tell people I do robotic mastectomies, they're like, why would you do that? What's the point? And I think that this session will address a lot of that.
Paradigm changes in therapy. What are you going to talk about?
And then, of course, we get to the topic which I think all of us have explored before, which is...
You two are geniuses for doing this. You have an inter-society...
just like AI, you can't go on the news now and not have people talking about hormone replacement.
De-escalation.
I'm really excited to go to Seattle. I think Seattle's... This is Carla,
Ellie,
Michael,
Susie,
and Susan. Welcome to The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community.
We're a group of devoted surgeons from different parts of the country,
inviting you to journey with us into the science of breast
through the heart and soul of our breast community.
From advances in procedures and patient care to personal transformation, we're here to support you.
So, if you're part of the breast community and can't seem to find the answers, this is the next breast thing.
If you're looking for a good reason to attend the 2026 American Society of Breast Surgeons Annual Meeting on April 29th through May 3rd in Seattle, Washington, this is the episode for you. We're not going to just offer you one good reason, but 10 important reasons to attend this meeting.
Whether you've never been to the ASBrS Annual Meeting or are among the countless breast surgeons who wouldn't miss it for the world, this episode is your inside scoop regarding the 2026 Annual Meeting.
With us today is the program chair of the Annual Meeting Committee, Dr. Deborah Farr. Debb is an associate professor and section chief of breast, skin, and soft tissue surgical oncology at Harold C. Simmons NCI-designated Comprehensive Cancer Center at UT Southwestern Medical Center in Dallas. Oh my goodness, Debb, please don't tell me that's how they answer the phone.
Me too. It would take a while, wouldn't it?
Yeah, that would take a while. Debb, welcome to the Next Breast Thing podcast.
Thanks so much for having me.
Well, we've got a lot of ground to cover, so why don't we just get started exploring the top 10 reasons why our listeners don't want to miss the 2026 ASBrS Annual Meeting.
There are so many good things that I'm really excited about. One of the things that Michael and I were talking about when we were crafting a name for the meeting, Seattle has the Space Needle, and so our idea was moving the needle, pun intended. So the reason why I was excited about that was because of one of the themes this year is cutting edge stuff new innovations in surgery. And that's what we got started with when we were crafting the program.
Let's talk about that. It is difficult to make it through a day, or really to make it through an hour, without hearing someone say, Chat GPT, Perplexity, AI, something, something, something. It is every conversation now. And it's working its way into medicine. We're all aware of that. Some people say too quickly. Some people say not fast enough. I haven't heard anyone say it's just right yet. So what should we expect to see at the meeting? Is it every topic's AI? Is it a little bit, a lot?
It kind of sneaks in most places, mostly because you're right. It's everywhere. It's ubiquitous. It's in not only like the note-taking stuff like Claude and a bunch of other names that I don't really know, and applications that I don't know how to use. I joke that my husband went to Chat GPT law school because anytime we're looking at a contract or something like that, he plugs it into Chat GPT and it magically spits out something. But it's also permeating things for healthcare too, like with breast imaging, pathology, the way that we keep records. And I think that for me, who is technologically very not advanced, when it comes to these note-taking applications or this really cool software that now is involved in all these different contraptions that we use at the meeting, when you go into the exhibit hall and you're looking at all the different things that are available to us, you really see how much technology has, again, moved the needle forward. And it's exciting to learn about all that stuff. It can be really intimidating, though, for someone like me. So I think it's cool to explore it, especially having the experts explain why we use it, what advantages there are, and explain how it's done. Really excited to hear about that.
A lot of people are going to be excited to talk about that. I mean, we obviously talked about it on the podcast not too long ago, and it's been a huge discussion point, as Susan said, this past year. So people always show up to the meeting, I think, really excited to catch up with people and catch up with friends. But there's definitely topics that people want to talk about, whether it's de-escalation or AI or different things that are going to be going on. And I think AI will be a big one this year. So looking forward to that.
We were at San Antonio late last year, and to see the involvement of AI at a meeting like that was incredible. It was throughout every session, AI in clinical trials and the difference that it's making in going through EMR and choosing patients for clinical trials. It really was incredible. And now clinical trials looking at AI-based education versus physician education to patients, and the difference is really looking at this in clinical trials is incredibly important. If we are changing the way we educate patients, that we treat patients, that we choose patients for different procedures, I think looking at a clinical trial is a great way to do it. So, Deb, to what extent should we expect to see AI, and can you tease us with some different topics?
Well, I think that you'd be surprised how many things it permeates. And honestly, when I was first thinking about AI, I was thinking, I want to know how that Claude Note thing works. It didn't really even occur to me that it could screen for my clinical trials that we run at UT, and it pops up an explanation, this patient might be a great fit. I was surprised. I was also surprised to hear about applications in breast imaging. I think that a lot of times, we're so focused on what we do. Breast is so multidisciplinary, but it's lost on me how much it's permeated what our colleagues do. So we'll be talking about AI in breast imaging, pathology, and then the practical applications that you spoke about with screening for clinical trials, and then applications that we can use from day to day to make our lives easier, to make note-taking, patient record keeping, screening, all that stuff. I think that will be just sort of the starting point. And then as we continue to go on throughout the meeting, it will continue to pop up, and we'll be surprised at how much it's really everywhere.
That's enough right there for me to show up. But I'm more excited, honestly, about the Hoag Hospital Surgical Innovation session that you've set up. Tell us about this.
What the Hoag Hospital Surgical Innovations session will be talking about is the robotic mastectomy, which is my second baby. The experience with robotic mastectomies, it's been approved in Europe for a little over a year now. Dr. Arnie Hill from Ireland will be talking about not only the technique, but the benefits, the risks, how he got trained, all those different things. Because I think there's a lot of curiosity and skepticism.
Yeah, that's going to be something I think people are going to attend.
I think the cool thing about talking about it is it's not something that you need to be on board with right away. I think that it's something that we need to investigate more. Bernie Fisher said, "In God we trust, all others must have data." We still need more data on this. It's still evolving, but we should talk about why people are interested in doing it. A lot of times when I tell people like, yeah, I do robotic mastectomies, they're like, why would you do that? What's the point? Right? And I think that this session will address a lot of that. It will make a lot more people curious rather than putting the brakes on it the way that it has been for several years, which has been healthy. But I think we're at the time now where it's going to happen.
So hot off the press is from the FDA, big news about robotic mastectomies, right?
Yes, the SP robot was FDA approved for breast surgery. It's FDA approved for urologic, ENT, and colorectal procedures, but recently it just got the stamp of approval for breast surgery, which is exciting. But I think there's still a long way to go. I think that we still need to be really responsible about how it's implemented, which is all the more reason why we should learn about it at the meeting.
I think that we're going to have to learn how to do robotic mastectomies. I think that's what Debb is telling us right now.
I was just in the operating room with a resident and medical student the other day, and they may not be aware. They're probably not aware that we're doing robotic mastectomies at this point. And a lot of them will talk about how they love breast surgery and they love working with the robot. I just had a medical student who told me those two things. And I said, well, do you know they're doing robotic mastectomies? And she said, no way. So it's fun to talk to people about that. And you're right. There is definitely the question of why do you need to do it? And we talked about some of the benefits that I know even you yourself have written about. But I think now that there is this FDA approval, as Susan said, are we headed back to do some training?
Our whole generation, we never did robotics.
Yeah, boy, the younger generation does, though.
Michael jokes about me being young, but I never had any sort of robotic exposure at all during residency. I think that it needs to be talked about, if not explored. Michael was actually in my OR a couple weeks ago, and he is always giving me a hard time.
Here's what you did, and this is what I think you're going to do in this meeting, is you're going to demystify this, because I had no idea what to expect. I watched you do this, and I was like, this actually makes a lot of sense. You're using it to get to those places in the breast that are so hard to get to, and so I was amazed how you made it look easy. But this is a real tool that I think is going to be adopted by a lot of people, especially if you're young enough that you've worked on the robots before. But like you said, maybe you don't even need robot experience to be able to get this done.
Ergonomically, it has to be better than doing a nipple sparing mastectomy. And
Totally. I mean,
it just is awful.
I was 9 months pregnant doing this. It was feasible.
This whole session's packed. Nerve reanastomosis, lymphovascular bypass. If you just came for robotics, you got 2 more to go. Let's keep going. Paradigm changes in therapy. What are you going to talk about there? What are we going to hear?
There are lots of new cool things that are going on in clinical trials that are important to highlight. Going back to my shift the needle thing, it's hard to change what we know works, but why? Why can't we do things a little differently? What are the benefits to doing things differently? So a couple of things that we're going to explore are neoadjuvant radiation. They do it in colorectal surgery. What are the benefits to that? One of the leaders of the clinical trials will be explaining the thought behind that. Cryoablation is another topic that we'll be talking about. Where and when that is beneficial. Why do we want to do that versus other therapies? And then, of course, we get to the topic, which I think all of us have explored before, which is surgery eventually becomes superfluous.
Michael, you sighed before she even got that out.
I've seen the meeting agenda. This is coming.
And, can it benefit our patients? What are the benefits and the risks? Why are we doing these trials? I think that it's really important to explore that. And sometimes the null hypothesis is the answer, but at least we explored it. It's going to be really interesting to see how these trials were made and what the results are. I'm really excited to have them speak about their data.
So let's talk about something I'm really excited about. And it may be because I was asked to moderate this session, but I think that ASBrS has really been out there time and time again as a society that wants to bring other societies together. As we get more and more into the multidisciplinary approach, I think that ASBrS is great at doing that at a society level. Rather than local politics, stay local, we are multidisciplinary in our local tumor boards and local breast meetings and things like that. but let's move that up several notches to the society level. And ASBrS has done that in several guidelines that it has put out in different meetings. But here, you two are geniuses for doing this. You have an inter-society roundtable, and you have an incredible moderator.
Well, I'm interested to hear about this session because it sounds great, but what are we doing at this roundtable?
Yeah. Why is this important, or why are we so excited about this? Susan hit the nail on the head. Obviously, you come to see the data. What's the newest thing? Meet your friends. But what does the society do for you? And what is the society doing in the multidisciplinary milieu of interacting with the other societies, collaborating, and serving our patients better? So this is actually Michael's baby. He pulled together the leaders of these societies to discuss how we can work together and why it's important, not only that we work together, but that you know that it's important that the society collaborates with other societies. We treat our patients with our colleagues from radiation oncology, medical oncology. We have to all come together to have one plan for the patient. And that goes from the microcosm of speaking with that patient in our clinic room all the way to collaborating with these other societies and understanding how we're going to work together as treatment changes. One of the examples are the sound and ensema trials and how we're working towards de-escalation. We need to work with our colleagues to understand, well, if I make this move, what's the next move that they're going to make? Does de-escalation on my end mean that they're ramping things up on their end? How are they crafting their guidelines in terms of these new changes in these clinical trial outcomes? Why is it important to understand how they feel about these different trials, or why they craft the recommendations that they do for different things? And then a step up from that is advocating for our patients on a bigger level, whether it be for leadership and advocacy with the ACS. I remember going to that meeting in April where people were on the Hill advocating for healthcare, not only reimbursement, but helping legislators craft what they do, because a lot of them are not obviously exposed to medicine the way that we are. But it's important to have a voice in that.
They're not just representatives from society. They are the presidents
yeah,
of the Society of Breast Imaging, the president of ASCO, president of ASTRO, and hopefully we can get the president of the college. We're still kind of waiting on that. So these are the people that are making these decisions within these societies. And when I called to invite them to do this, they were blown away and excited. And they see us as the go-to for breast. And that's what is important, is that our society are seen by these other societies as the go-to for breast. And I think it's important that we're on that stage with them and that they're on that stage with us.
And I think that a great example of this is American Society of Breast Surgeons undertook releasing new guidelines for benign breast disease, which is critically important. But we really couldn't do that alone because we don't operate in a vacuum. So we're SBI, Society of Breast Imaging. Our first guideline was released jointly with them in JAMA Surgery. And then we have another one coming up with SBI and CAP also, correct, Michael?
Correct. There's actually 4 total. So
Right.
CAP's going to be on number 2, 3, and 4.
This is really progress on a societal level. So the thought that you and Debb have gotten all these society presidents together, a past president moderating, it's just going to blow our minds. After this, there's something that's tried and true. And as long as I can remember at our annual meetings, we've had the great debates. And this is one of those sessions that everyone loves. I think that the 2 sessions that people look forward to are the great debates and the most famous session of all, Helen Pass's papers.
Helen has agreed again to do that. So we're excited about that. Thank you, Helen.
I've spoken to Helen about who's going to follow her.
who gets that spot after her, because everybody is always in that session. Always wants to know like what the best papers are.
Helen Pass's best papers, and I feel sorry for whoever is following her. My question is, how do you come up with the topics for the debates? Because it's tough.
It is, but I think that unlike some other things where we might not have a whole lot of content, the debates, it's like you have too many things to pick from because there's all kinds of controversial things. It's really picking the ones that sound the juiciest.
I like all 3 topics. The one topic I think is going to be one of the most interesting ones.
HRT.
Absolutely.
Of the 3 topics, I would love to hear what our audience thinks. The 3 topics are local therapy in stage 4 disease, HRT in high-risk patients, in cancer patients, in average-risk patients. I think this is such a hot topic. And then PMRT in 1 to 3 positive lymph nodes. So I would love to hear from our audience on any of our social media sites. What topic is your favorite topic of the great debates? Maybe we can have a pre-question and put that up at the meeting.
Oh, that's the best. I love that. Yeah.
Let's do that. So, Carla, which topic is your favorite of these?
HRT. Just like AI, you can't go on the news now and not have people talking about hormone replacement in all women. A patient told me that a doctor spoke to her and she said that she believed every woman who's postmenopausal should be using vaginal estrogen for various reasons. I think that we all have hot takes on different things. Obviously, that's sort of just one component of HRT. But personally, I think people professionally are very interested in that. And obviously, we have patients where it's especially significant for because we're taking care of patients who've had breast cancer or have breast cancer now or are high risk for it.
I had a patient today who was just diagnosed with breast cancer on HRT and told me that her doctor told her she caused her own breast cancer. We have no way to prove that. Absolutely not.
We ought to debate it.
That's a great idea.
I just came up with that. My favorite is going to be post-mastectomy radiation in 1 to 3 nodes. I got to tell you, we are de-escalating, and I don't know that radiation oncology is de-escalating as much. I would love to hear the counter argument.
I've been privy to some of the emails that they've sent to each other back and forth, and it's going to be great. They both have a great sense of humor. And I love that it's a radiation oncologist who's actually going to be treating these patients, giving the reasons why or why not they would or would not radiate in certain circumstances. So
I might have changed my mind. I don't know. I'm between those two.
So I'm still with HRT. Evidently, the FDA's had a few busy months. They just approved the 3rd non-hormonal treatment for hot flashes.
And they removed the black box warning.
I'm sticking with that's my favorite topic.
Susan and I, we both attended San Antonio Breast Conference, and every company there has MRD, minimal residual disease testing. Are we going to talk about that?
That's a whole session as well. All our patients are interested in what these blood tests mean, how they should be applied, how they can be followed. What is the data? That's what we're going to be talking about. MRD, I-SPY, other genomic tests. What is the current status of them? I think that those topics are going to continue to be even more important as breast care becomes more specialized. And I think it's really important to know what is there to know, what tests are most important, and then what are the clinical trials that are ongoing and what should we follow going forward.
The amazing thing is right now, when we do not have any data to say that diagnosing metastatic disease earlier changes outcome. Presently, there are 15 to 20 companies in this space and growing. I mean, a year ago, there weren't 15 to 20 companies, but that number just continues to grow. It is such an incredibly important topic, and without a doubt, it is here to stay.
Yeah. And what does this mean for our patients? What does this blood test mean? Are you going to change your management? Does this put me at a higher risk? And we need to explore what we know so far and then how we're going to continue to track these things.
De-escalation. You're going to cover de-escalation at all?
De-escalation, does that mean that we're escalating in other arenas? If I decide to omit a sentinel node, does that mean that they're going to get more radiation? If we omit sentinel node, does that mean that they are more likely to get further care along the line that we could possibly omit if we did do a sentinel node at the beginning? We have to understand the checks and balances as breast is so multidisciplinary. When we make our decisions, that affects decisions down the line. So we need to explore the sound and semen trials. This will be probably a session after the great debates and people have opinions about PMRT after 1 to 3 positive lymph nodes. We'll have to see what choices impact other disciplines.
We're all on these different text groups where we share things with colleagues or friends and asking questions or tumor boards. And this actually just came up with a group that I asked questions to, and it was about a medical oncologist asking a surgeon to do an axillary dissection. The clinical scenario made sense. I won't go through it, but I think it had to do with the decision to recommend CDK4/6 inhibitors or not. And so just like omitting the sentinel node, we've been omitting the axillary dissection for quite some time and feel very comfortable with outcome data based on that. But with some of these newer drugs in estrogen receptor positive disease, I don't think we're going to start doing axillary dissections, but we do need to talk about it. We need to know how to talk with our medical oncologist about this. And should we continue to de-escalate ax dissections in those situations?
Yeah, and if we don't have that data, then what data are they going to use to make those decisions?
Okay, we're running out of time. Michael, most exciting thing you are looking forward to?
The fact that this is going to be innovative, it is going to move the needle. We didn't even mention some of the health aspects that we're going to be doing and GLP-1s, diet and exercise. So we're including things that are really cutting edge for this meeting. So it's going to be less about rehashing the old, but it's really going to be looking forward into the future. I am so excited about what Debb's put together on this.
Carla?
I think the topics are great. So not to rehash them, I'm really excited to go to Seattle. I think Seattle's a great city. I think it's a great place for people to travel to. I was able to see the convention center and have been there before, and I think it's a great location.
Well, I cannot believe we are out of time. We definitely covered far more than the top 10 reasons. This is such an exciting and innovative meeting that you've put together. So thank you, Debb. It's truly been a pleasure having you with us on this episode of The Next Breast Thing.
Thanks so much for having me. I'm super excited to get to Seattle, see everybody, and see what y'all think of all these sessions.
Registration is open. In order to register, please go to breastsurgeons.org and get the early bird special. To our listeners throughout the entire breast community, we're so excited you've joined us on this journey, and we'll see you next time on the Next Breast Thing podcast.
We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, the content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla,
Ellie,
Michael,
Susie,
and Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.